ம்
லைவ்ல இருக்கோம். ஓகே ஓகே.
படிக்க வேணாம் சார். ஆன்லைன்ல
Sir, we are live, sir. Please begin.
ஆன்லைன்ல இருக்கானா? ஆ
Good evening, everybody.
அவன் ஆன்லைன்ல இருக்கா சார்?
Good evening, everybody. After maybe 1.5 months, we are starting our live session because of some reasons. And without wasting time, I welcome my professor, sir, my guide, Professor Manoharan, sir, from Puducherry. Sir, hearty welcome to you.
Yes, sir.
Thank you very much for always supporting me, sir. I know here, sir has written foreword to my 8th edition book and always supportive to me. I welcome my dear friend, Professor Muthukumaran, sir, from Savita Medical College, Chennai. Sir, thank you very much for joining. I welcome you wholeheartedly. Thank you, sir. I welcome Keshav Prasad, KVG Medical College, India. He'll be joining soon. I welcome Robinson George from Kuruvella, and he is Tiruvella. He may be joining because he has got some personal work as such. Otherwise, he is regularly will be there in my website. In his absence, I welcome him. I welcome Swarnava and Samkit Jain, final year students from Keshav Medical College, Mangalore, my own college, who are presenting today. And I welcome all viewers through YouTube and all faculties and who are supporting me and everybody to join the session. Without wasting time, we'll go ahead with the presentation, sir.
Yes, sir.
No, sir, Muthukumar.
Yes, sir. Please.
Presentation. I think Swarnava is presenting the history. We are discussing today examination of ventral hernia because it is a very common case in the exam. Exam will become very important for UGs, specifically how to examine and how to discuss the case with the ventral hernia. So we'll just straight away go ahead with the Swarnava to present the history.
Yes, sir. Good evening, one and all. I'm Swarnava. I'm a final year UG from KMC Mangalore. I would begin by thanking sir for this introduction and opportunity. So today we are discussing a case of ventral hernia. So we see a...
1 minute. Keshav,
yes, sir.
Keshav, good evening. Welcome. Keshav, very much. Keshav, from KVG Medical College, Professor in Surgery Department, my good friend. Keshav, welcome. We just started.
Yes, I was trying to join. There was some technique.
Over to Swarnava.
Yes, sir.
Good evening, sir. Keshav, sir. Good evening, sir.
Here we see a 33-year-old female whom we are abbreviating as Mrs. X. She is a homemaker by occupation and she belongs to the upper middle class socio-economic status according to modified BG Prasad classification, and she is hailing from Kasaragod, Kerala, and she presents with complaints of swelling in the abdomen since the last 4 years. Please, can you... Yes. Swelling in the abdomen since the last 4 years and history of presenting complaints. Next slide, please. Yes, patient was in her usual state of health 4 years ago when she had pain in the sole of her left foot, and during that examination they incidentally noticed, the physician who was visiting, that is, a small swelling around her umbilicus. Swelling was insidious in onset and gradually progressive. Initially it was of small...
Swarnava, your voice.
Yes, sir, I got mute. Can you please go back to the previous slide? Yes, thank you. Patient was in her usual state of health 4 years ago when she had pain in the sole of her left foot, and she went to a physician for examination, and during that examination they incidentally noticed a small swelling around her umbilicus. The swelling was insidious in onset, gradually progressive from its initial small size, which was around 1 into 1 centimeter, to its current size over the last 4 years. And it increases on lifting buckets and straining, and it reduces on lying down. Next slide, please. Yes, it was not associated with any pain. 1 week back, she had gone for a regular gynecological checkup due to increased flow and got USG abdomen done. And from there, she was referred to our hospital, which is Wellock Hospital, for further management of the swelling. There is no history of any previous surgeries. There are no history of any trauma. Next
पूरी
slide,
है
please.
कि सर हम सारा से लेंगे चॉकलेट
There is no history of any chronic cough or any chronic respiratory complaints, no history of any fever, no history of constipation or any urinary symptoms, and there is no history of any chronic abdominal distension, vomiting, or irritability of the swelling. Next slide, please. Past history. She is not a known case of hypertension, diabetes, mellitus, tuberculosis, asthma, COPD, epilepsy, chronic kidney disease, or cardiac disorder, or any other comorbidities. There is importantly no history of any previous surgeries or tubectomy done, and there is no history of previous blood transfusions. Now coming to her menstrual history, except for the last one where she had increased flow, she has been having a pretty normal menstrual history. Like she attended menarche at the age of 13 years, regular cycles of length around 30 days, bleeding for 2 days, and she changes pads 2 to 3 times a day. No dysmenorrhea and no clots. And her obstetric history, she has been married for the last 14 years. Her obstetric score is para to living to. Her last pregnancy was 8 years ago. Her first child is a 12-year-old female and her second child is a 9-year-old male. Both are delivered by normal vaginal delivery without any complications. Yes, family history. She is the first daughter of a family of 6. Her parents are alive and doing well. Her mother has diabetes mellitus, but other than that, they don't have any comorbidities. And all of her 3 sisters and 2 brothers, they are all doing fine. And she's the first person in her family to have such complaints. Yes, personal history. She consumes predominantly non-vegetarian diet. Appetite is normal with no recent history of weight loss or weight gain. Her sleep is adequate, and she's not on any regular medications. Her bowel and bladder habits are also regular. No history of any alcohol consumption, smoking, or drug abuse. Yes, history summary. 35-year-old female homemaker presents with complaints of a solitary swelling in her abdomen. The swelling is insidious in onset and gradually progressive from its small, around 1 by 1 centimeter size to its currently around 3 by 3 for the past 4 years. And it is not associated with any pain or other symptoms. It increases in size while performing any strenuous activities and reduces on lying down. There is no history of any previous abdominal surgery, trauma, chronic cough, constipation, weight loss, or other conditions which may lead to raise in the intra-abdominal pressure.
Shreya will go back to the chief complaint. First slide. Subisha will go back to the chief complaint. First slide. Next. Okay. First slide. No. Chief complaint. Top.
Yes.
Manoharan sir, Muthukumar Keshav, anything to comment or ask questions, sir?
Nothing, sir.
Nothing. Keshav, sir.
He can mention upper abdomen, that's all, nothing else.
Upper abdomen, okay, sir. Should have mentioned which area, above the umbilicus or below the umbilicus, should have mentioned that. That's right, sir. Next slide. Subisha, next slide. Okay, hold on. Sir, Manoharan sir, Keshav, Muthukumar sir, he said he...
So as sir pointed out, it is not around the umbilicus, above the umbilicus.
Yes, sir. It should be above the umbilicus.
Above the umbilicus.
Above the umbilicus. History-wise, it should be above the umbilicus,
Yes.
not around the umbilicus. That's right.
Buckets and straining.
Here you mentioned it increased on lifting buckets. You
Weight.
can say instead of specifically mentioned bucket, you can say lifting weights.
Yes, sir. Yes, sir.
On training.
Not only bucket, any weight.
Any.
Any weight, yeah, lifting
Yes, sir.
better word rather than buckets. Okay.
Next slide.
Okay, that's right. We'll go to the next slide. Sir. Next slide. It was not due to pain. Other than why pain you have asked? What are the causes for pain, if at all, if it happens?
Sir, any obstructed hernia, any incarcerated hernia, those can present with pain. Like dragging kind of pain can be present if there are adhesions inside. And more severe pain are seen in obstructed hernia and any such emergency causes, sir, to rule them out.
Okay. Without obstruction, can they have pain?
Yes, sir. If there are adhesions, then she'll have dragging kind of pain, sir.
Okay, and it's omental adhesions without
Yes, sir. Mental adhesions.
So the history says, you said no, on lifting weights,
Yes, sir.
it appears. So that means the content tries to come out through that herniation. That time the patient may experience some pain.
Yes, sir.
Not necessarily always pain should be obstructed and then strangulated. So that is the extreme end. Even otherwise, if there is a defect is too small, the content is herniated through that will cause some amount of pain.
When the content appears in the sac, then they will have pain, dragging pain or some sort of discomfort they will develop. If you ask
Yes, sir.
typically.
Yes, sir. We asked there also. She was like, no. It was very asymptomatic.
Okay.
Otherwise, usually they will have some dragging or discomfort when the content descends into the sac. Okay. So, okay. Next slide. Sir, anything, sir?
Yes, sir. Previous surgery is trauma. Yes, mentioned correctly.
Okay.
Right. Next slide.
Okay. Trauma, how it related?
Sir, any as any secondary cause due to any kind of abdominal wall weakness.
So any trauma means first thing is always think of hematoma.
Yes, sir.
Injury means there is a hematoma, na? Huh?
Yes, sir.
So
Yes,
bleeding, that swelling may be a chronic hematoma, which
Yes,
is
sir.
presenting like this. That is it. Okay.
Keshav, anything to comment? Next slide. Next. Okay. Chronic cough, nausea, fever. Why fever you asked?
Sir, any fever means any kind of peritonitis or like any pus collection in that area. So to rule out again, there are those emergency conditions. Even with strangulation and all, because of increased inflammation and all, there will be fever.
Correct, but always you are going to the extreme, extreme and simple things first. So I remember that there is a hematoma means suppose it gets
Yes,
infected.
sir.
If it gets infected,
Yes, sir.
okay, chronic hematoma getting infected, then there will be inflammatory signs. Okay.
Yes.
Your peritonitis and all is a generalized this thing, too complicated for such a small case.
He is thinking only of hernia and left that. Because your exam is not at all.
So it's going on telling that dragging pain.
Just you have seen a swelling, so it could be so many things. That's what exactly Professor Sir is informing you. Okay, you are not concluded that it is a hernia as such, even though history suggests. Okay,
Yes,
so
sir.
something else is possible also until you finish your examination. That's what exactly Professor Manoharan Sir has informed. Okay.
Yes, sir.
One more. Previous slide, please.
Next slide. Next slide.
Next slide. Now you have constipation or why you are worried about constipation? Cough.
Sir, cough will increase the inter-abdominal pressure, and constipation also similarly will increase the inter-abdominal pressure. And she is exerting more pressure, there are more chances of hernia to
So
develop.
instead of mentioning urinary symptoms, you have to mention difficulty in mixture.
Difficulty in mixture.
Yes, sir.
Urinary
Yes, sir.
symptom may be frequency, urgency, so many things are included in urinary symptom. Anything
Yes, sir.
that raises the intra-abdominal pressure only we are worried.
Yes, sir. Yes,
Any
sir.
difficulty in micturation you have to mention. Not all urinary symptom, any urinary symptoms. You must be
Yes.
specific. That's all.
Difficulty in urination. Difficulty in maturation is the more relevant than just urinary symptoms. Okay.
Yes. Yes.
Okay. Distension, omitting. Why distension, omitting, great disability history? You asked?
Sir, all this can be seen in obstructed hernia, so we have to treat her immediately in these cases.
Again, you are mentioning chronic abdominal symptoms. It's very vague term. And it's a 4-year duration. Patient is otherwise asymptomatic. All the things are come and the patient is having emergency. Is incidentally being pushed to our
Keshav?
Yeah,
Keshav,
it's getting muted automatically. It's that this patient didn't have any symptoms as such. It's just being referred to hospital for treatment. Rather than being symptomatic. So again, these are all acute conditions. No?
Yes. Yes, sir.
But what I'm telling you, don't mix up both the acute symptoms and chronic symptoms. Or if
Yes.
asymptomatic patients and whom you could not tell, they ask for all this acute symptoms.
Yes, sir. Yes, sir.
Next slide. Next slide, sir.
Sir, just a second. Keshav sir, I think your audio has a problem. Once you turn on, some back noises coming. Please check that. We'll cut this part.
No worries. I'll just keep muted till no problem.
Okay, anything to comment on this, sir? Manoharan, sir,
Yes.
sir, Keshav.
Why specifically tubectomy?
Yes.
Sir, because she already had like 2 children, like both of them are like last one was like 9 years ago. So we were like asking for tubectomy specifically because it can be done laparoscopically, and even on inspection we can miss the scar and all. So we specifically asked for that, sir.
Right.
Why blood transfusions?
Yes, sir.
Why blood transfusion?
Sir, any any kind of hematological disorders, like so we were thinking like that.
What is its relationship to hernia? Relevance.
Why specifically you are interested in asking blood transfusion in this space?
Sir, we asked it like routinely, because generally routinely we asked for.
You have read some fine print that you are not wanting to tell.
Why not sure why specifically asking about blood transfusions?
Sir, like it can cause hematoma, like if there is some acquired factor deficiency. So it can maybe precipitate some kind of autoimmune condition which can cause hematoma.
Right, proceed.
Next slide. Anything to comment on this, sir?
No, sir.
Oh, sir, okay.
No, sir. Next slide.
Next slide.
Family history.
Family history as detailed. Next slide.
Yes.
Next slide.
Next slide.
Anything to comment on this?
No, sir. No, sir.
Sleep adequate, not on regular medications. Oil bladder. Why regular medications you asked?
Sir, for anticoagulation, if she's taking anticoagulants, you have to stop it before surgeries, 5 days before surgeries. So for that, I've asked.
Okay.
Next slide.
Next slide. Anything to comment on this, sir? Because inside size performing, trauma, cough, constipation, weight loss. Weight loss? Why you asked weight loss?
Sir, weight gain or weight loss, like weight gain can precipitate hernia because she's becoming like more, whether she's becoming more obese, so more increased intra-abdominal pressure, and then weight loss, sir, in case any kind of malignancy she's having inside, which is again increasing the intra-abdominal pressure
Okay.
in the abdomen.
History, okay. 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 History of ascites any significant?
Yes, sir. Ascites will again cause the increased intra-abdominal pressure. Like, so we asked about that, sir.
Okay, sir.
We'll go ahead, sir. Next,
Yes, sir. Yes, sir. Next slide.
Keshav, Muthukumaran, sir. Next.
Next slide.
So, complete representation.
Yes, sir. Good evening, everyone. So, in general physical examination, the patient was conscious, cooperative, and well oriented to time, place, and person. The consent was taken and examination was done in well-lit room in presence of female saffron. Patient was well built and adequately nourished, and Krasnowski performance status was 90%. Next slide, please.
Submission, next slide.
Next slide.
Vitals, the temperature was febrile. The pulse rate of 68 beats per minute in left radial artery, regular rate, normal volume, normal character, no vessel wall thickenings, and all peripheral pulses were felt and no radial delay. The blood pressure was 114 by 84 millimeter of mercury in left arm sitting position, and the respiratory rate was 15 per minute. SpO2 level was 98%. There was no sign of pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or pedal edema. The thyroid and spine examination were clinically normal. Coming to local examination, inspection is done on a standing and supine position. Abdomen appears free. A solitarily spherical mass, approximately 3 into 3 centimeter, is in size is observed above the umbilicus and located just right to the midline of the umbilical region. The surface appeared smooth and margins were well defined. The skin over the swelling as well as the surrounding skin appear normal. The swelling is having expansile impulse on cuffing. On lying down, the swelling reduced considerably. Umbilicus is central and flat, skin colored, oval in shape with a shallow central skin. On leaning forward, there is no change. Uh, on leaning forward, there is no change in the swelling, no scars, sinuses, or dilated veins seen. There is no visible pulsation or peristalsis, and all quadrants move equally with respiration. Next slide, please. Coming to palpation, there is no local rise of temperature. There is no tenderness or guarding present. There are two palpable swelling. The second one was not appreciated on the inspection. The first swelling is a spherical, smooth swelling of size 3 into 3.5 centimeter in size, palpated 1 centimeter above the umbilicus and 13 centimeter below the xiphial sternum, located right to the midline in the umbilical region. It is non-fluctuant and its border were well defined, doughy in consistency, and the margin were well defined. It is reducible and not fixed to the overlying skin. There is expansile cuff impulse. It is non-mobile and the surface appears smooth. The second swelling is irregular swelling palpated just below and left adjacent to the umbilicus, 1 into 1.4 centimeter in size, and the margins were clearly defined on cuffing. It is a reducible and not fixed to the overlying skin. Its superior medial border is formed by the umbilicus and it is doughy in consistency. There is expansile cuff impulse. It is non-mobile and the surface appears smooth. Firm ring-like fibrous edge felt after the reduction. Defect is appreciated by asking the patient to raise head with arms folded over the chest. Abdomen muscle tone was normal. In percussion, liver dullness along the fifth intercostal space in mid-clavicular line is present. Dull note over the swelling is also present. Other area of the abdomen is free fluid. Auscultation, no bowel sound heard over the swelling, no bruit were heard. Bowel sound were heard normally in the other regions. Lymph node examination, there was no significant lymph node felt, and digital rectal examination was not done. Systemic examination, CVS S1 S2 were present. There was no murmur. CNS, there was no focal neurological deficit. In respiratory system, normal vesicular breath sound were heard bilaterally. Summary after examination. On examination, two spherical non-tender swelling were palpated in the umbilical region. One swelling measured approximately 3 to 3.5 centimeter, located 1 centimeter above the umbilicus, and the second measured 1 into 1.4 centimeter, situated at left and below the adjacent to the umbilicus. Both swelling were reducible, due consistency, with a smooth surface and well-defined margins, and it shows expansile cuff impulse. On auscultation, no peristaltic sound or bruit were heard over the swelling. Bowel sound were normally heard in the remaining abdominal region. On percussion, a dull note was elicited over the swellings.
Next slide. Samkit, tell me, Samkit.
So,
Yes, sir. In clinical diagnosis, reducible uncomplicated primary ventral epigastric and paraumbilical hernia with omentocele without any obstruction or strangulation. And differential investigation.
No, go back.
Go back to the first slide.
First slide, inspection. Subiksha, inspection. Back, still back. Still back.
Previous slide.
Subiksha. Subiksha, previous slide. Okay, here only. Back, one more. Anything to general examination, sir, to comment? Manoharan, sir.
Nothing much.
Nothing. Okay, next slide. Yes, sir. Keshav, Muthukumar, sir. Manoharan.
Can you tell us why you did the examination, inspection on standing and supine position?
So to check if the swelling is reducible on lying down or not, and it increases on standing up.
But here it is visible in lying down also.
Yes, sir, but it was taken photo while the cuff impulse was seen.
Okay.
Anything? Okay, sir.
Next slide.
What is expansile impulse on coughing? What is the definition?
There's expansion of the hernia, the defect in the abdominal wall due to the connection of the hernia to the intra-abdominal.
Are you sure it is either cough impulse or it is expansile cough impulse? Difference is there. You know what is expansile cough impulse?
Expansile cough impulse means. What is the definition? Sir, no?
sir, there is a bulge in the area at the point of coughing because of increased abdominal pressure.
What definition is little different actually. It's a momentarily increase in the size of the
yes, sir.
Or appearance of swelling during the act of straining. Okay, that word momentarily is important. Understood? The definition is momentarily increase in the size of the swelling or appearance of swelling during the act of straining. Okay, yes. That is the word momentarily is very, very important when you define expansile impulse on coughing. Okay. Then reducibility is reducible. Umbilicus is set on leaning forward. Why you wanted to lean forward?
Sir, to check because we are suspecting of a hernia, so we have to differentiate from any abdominal wall content or intra-abdominal mass.
Oh, you are telling whether it is abdominal wall, intra-abdominal or abdominal wall.
Yes.
Parietal or intra-abdominal. Which test you will do to know whether it is parietal or intra-abdominal? An inspection.
Specific test.
You ask the patient to do something.
Upper abdomen, what mentioned? Lower abdomen.
Yes, sir.
You actually mentioned it in the
You
clinic.
mentioned in subsequent slide.
Yes, sir. To lift up the head while keeping the
Head raising, head
hands on-
raising
yes,
test.
head raising, sir.
Okay. More
Next slide.
parietal. Okay.
Sir, one thing, here you have mentioned that there is only FPS swelling. Next slide you have written, while palpating irritant expansile torsions, you can umbilical. Difficult to, it should be seen. Is it not? The umbilicus, there is another hernia.
Sorry, sir. I can't hear, sir.
No, there is another hernia you said, right?
Yes, yes, sir.
So that also you told. Again, you told that here is not seen, is it?
No, sir. We can't feel the hernia in the lower part. On expansile curve impulse also, we can't see that one.
Lower part impulse is not felt, is it? But you said
Because we can feel the but cannot see the in inspection cannot see the impulse.
you could feel the defect in the lower part. Lower swelling, lower hernia, you could feel the defect.
Yes, sir, we can feel the defect was present, but it was very small.
So you are telling two hernias are there. What it is called as?
It is called Swiss cheese appearance or Swiss cheese hernia.
Next slide.
Next slide. So, sir, anything to comment? Why local rise of temperature?
Sir, to see any strangulation or infection is there or not.
That is about abdomen or particularly about the swelling?
Entire abdomen or particularly both swelling you are looking for this local rise of temperature and tenderness?
Sir, both we are checking, sir. Both.
Why?
Both you are checking. Okay.
Yeah.
Dovi and Dovi inconsistency means what?
Sir, it shows the presence of omentocele. That's why it's doing consistency.
You have to directly mention the consistency bit. You have mentioned not fluctuant. Fluctuation is tested only after you test the consistency. The consistency.
Yes, sir.
What swelling you expect fluctuation?
Yes, sir, but I have checked the fluctuation to rule out any cystic swelling in the abdominal wall.
It's not like that. In the soft swelling, you check for fluctuation. In the swelling is firm, there is no fluctuation.
Yes.
Okay, we'll go to the slide, sir.
Skin is, you must say whether skin is pinchable or not.
So
Yeah,
skin
skin-
was
The
pinchable.
last slide you mentioned skin is free. So you should always say whether skin is pinchable or not.
Okay.
Okay, then
It's free. If it is skin is not free means what?
So it is there is adhesion present between the hernia and
In which situation in hernia skin cannot be able to pinchable,
barometer.
cannot be free.
in the incisional hernias mainly it is not free.
Okay, in strangulation, it will be better to
Strangulation, yes, sir. Strangulation.
it will be redness. All features of acute inflammation also may be visible and may not be able to pinch also. It will be adherent to the skin. Okay. Okay. So, sir, next slide, sir. Anything
Yes,
to
sir. Yes, sir. Yes, sir.
next slide. You said defect is appreciated by asking the patient to raise the head. Why?
So it contracts the rectus abdominis muscle and we can easily feel the defect.
But what happens to the swelling when the patient raises the shoulder?
So there was no change. Yes, sir. There was no change in the size while
no change in appetite.
No, sir.
Have you abdominal muscle tone?
Yes, sir.
Abdominal muscle tone, how you have checked?
Sir, in the same position, like we tell the patient to lift up the head, and we feel the abdominal wall. When it is firm, then the tone was normal.
Okay. Okay. Why it is important?
To check for any, if there was to, then it may cause to the hernia. And
For management purpose also, sir, we have to check. Depending on the tone, our management may differ.
How it differs?
Sir, whether or we'll place mesh or not, because if the abdominal tone is low, then higher chances of recurrence is there, sir. So you have to manage accordingly.
Since you have mentioned about rectus muscle, so I don't know whether you are aware. We have divergation of recti. That's time when you
What is the difference between the divergation of recti and hernia? That's what sir is asking.
So both of you talked about rectus muscle. I thought you will be able to tell. Yes.
Sir,
You know that condition, there is something called as divergation of recti.
Yes, sir. Sir, in divergation of recti muscle, firstly, we won't be seeing expansion cuff impulse. So here it is positive, sir. So that and generally the muscle tone also, like on laying down, it doesn't go back inside also, like we saw in this hernia case from standing to supine position. So like that,
when you put the muscle into contraction, like your head raising test and all, you can see the diverged muscle on both sides like a strip when it is contracted. So you can visually, you can see and inspect itself. Okay. And before you conclude the abdomen, you must say, with such a huge thing, you must say whether there is any free fluid, you should say. Any free fluid, any organomegaly.
Yes.
Yes, yes.
So the two things you should mention, because you talked about in a raised intra-abdominal pressure. So sort of general examination, you should say there is no ascites or no free fluid. On palpation, there is no organomegaly.
Yes.
Organomegaly, you have to mention.
in palpation, you mentioned only about the umbilical hernia. What about the epigastric hernia? You are not mentioning anything about epigastric hernia in the inspection, you mentioned only about epigastric hernia. In palpation, you are only talking about umbilical hernia. Could you make a defect in the epigastric region?
Yes, sir.
Where have you written that?
Sir, in the first sitting was in the epigastric region only, in epigastric hernia only.
But where is the respiratory finding of that swelling?
Sir, it's in the previous slide.
Previous slide, sir.
That is inspection.
No, sir. Palpation first.
Previous slide.
Please go back to the previous slide.
The expansion process.
Next slide.
Next slide. Did you check for any impulse on coughing in the umbilicus?
Yes, sir. It was not present, sir.
You should mention it because there is a swelling above the umbilicus and on the side of the umbilicus. Always make a mention whether the palpation, I could not feel any impulse in the umbilicus per se. Okay.
Okay, sir.
Yes, next slide.
I think when the patient is having two hernias, the intimate region also
Okay, sir.
because that's very important. Patients got the tendency of herniation even if the most common factor.
Next slide.
You are approaching this case as a case of hernia, but
Yes, sir.
you have to approach it as a case of some abdominal pathology. In that case, abdominal examination must be complete.
Yes, sir.
When it is complete,
Yes.
as Dr. Manoharan pointed out, you have to mention whether the patient is having any mass in the abdomen, any other mass,
Yes, sir.
any other organomegaly or ascites. You have to mention. So usually when we talk about
We have
abdomen,
written
we have to
percussion.
mention, because big renal tumor, big ovarian cyst can cause hernia because of increased pressure. For completion sake, always you have to mention whether the flanks are free, hernial orifice free, renal angle. When you talk about abdomen,
Yes, sir.
you have to talk about flanks, hernial orifice, renal angle. Then only it will be
Yes, sir.
complete. There may be huge renal enlargement, kidney enlargement. So that has to be ruled out.
Okay, sir.
Hernial orifice you have to specifically mention.
Inguinal hernia orifice you have to mention. Then
Hernial
maybe
orifice free.
not mentioned that.
Yes, sir. Yes.
You have to expose and you have to mention inguinal hernial orifice.
So history says 3 children and she has been operated, no?
Even though he is a female patient, which is not common.
So she has got a sterilization scar. So we have to mention whether there is any defect there over the operated site, the lower abdomen.
No, sir. There
No,
was
sir,
no
there is
operation.
Yes,
She didn't get the sterilization done.
no, sir, no tubectomy was done.
Okay, right.
He mentioned specifically no
Yes, sir.
tubectomy.
Yes, sir. Right, good. Explain.
Especially in males, you have to examine inguinal region. Females also you have to examine, because in female, inguinal hernia is common in males, but in females, still inguinal hernia is common.
Yes, sir.
More than femoral hernia. But ventral hernia is very common. Interstitial hernia, umbilical is very common in females. Okay, so you have to mention about inguinal region in all patients when there is a ventral hernia, umbilical, paraumbilical, epigastric, and so on. Okay.
Okay, sir.
Okay. So
Next slide, sir.
next slide. Okay, percussion. He has mentioned no free fluid here. Dull note over the swelling means what?
Sir, momentum is present in the if dull note is present.
Suppose it is recurrent.
Yes, sir.
Resonant means?
Suppose it is
Resonant means viscera, sir. Intestine. Bowel.
Enterocele.
Enterocele, sir.
Bowel.
okay.
Okay, next slide.
Next slide. Okay, lymph node. Which lymph node you are?
Lymph node you have to say.
Sir, axillary and inguinal lymph node.
Hey, Baba, it is abdomen case.
Sir, we also check for supraclavicular, left
Any
supraclavicular.
abdominal, any abdominal pathology, always remember the
Yes, sir, we check for left supraclavicular virtually.
okay.
Why you want rectal examination?
Sir, to check for any rectal or anorectal strictures, which can cause to constipation or increased abdominal pressure.
In male patient for BPH, benign prostatic hypertension, or we can check, sir.
Prostatic enlargement.
Prostatic.
Any prostatic
It's a
enlargement.
prostatic enlargement in males, but in female we'll check for any rectal or anorectal strictures.
Okay. Okay. Okay, sir. Anything rectal, which at least you should mention in the case sheet, even though may not be able to do in the exam, they should mention it. It's important. Please. So free fluid rectal exam, the organomegaly like
The patient is female, so remember to mention the pervaginal examination also.
vaginal examination also you have to mention.
Okay, sir.
Not done, you better to mention. Okay, but write in the case sheet. It is to be done, but not done because consent is not taken. At least you have mentioned that you should be able to answer what to look for. So always you have to write case sheet in hernia or abdomen cases. Rectal examination is very, very important. Okay.
Yes, sir.
Next slide, sir. We'll go.
Yes,
Next
sir.
slide. Okay. Next slide. Submission next slide. Okay. Systemic examination. Anything to comment, sir? Keshav Muthukumar, sir.
Nothing, sir.
Okay. Next slide. So summary. Anything to comment? Dull note was written down. The swelling. Dovey note. Fine margin. Aspirant cell. Aspirant in cuff impulse. Anything to comment?
Nothing, sir.
Keshav?
Dovey note is in favor of momentum. Smooth surface is in favor of enterosil.
Okay.
So,
Okay. We go to next slide, sir.
Next,
yes,
next,
sir.
next.
Yes, sir.
Reducible uncommon primary ventral epigastric paraumbilical hernia. Comment without any obstruction strangulation.
Just put any without any complications.
Uncomplicated, you mentioned.
Then already you mentioned reducible, uncomplicated. Again, you are telling without any obstructions. It is obvious, no?
Once you say uncomplicated, why you want to put without any obstruction?
Without any obstructions.
You are trying to extra quantify this because it's only uncomplicated itself means it is reducible and it is not strangulated or obstructed.
Double guarantee.
Even primary and ventral.
But you missed out irreducibility.
Primary
There is no need to obstruction.
It is a primary ventral epigastric reducible without any complications. That will be idea.
Yes, sir.
Without any complication. Once you say uncomplicated, there is no need to write obstruction and strangulation. Diagnostic, you are written one lipoma, dermoid cyst.
Yes, sir.
Why is this differential?
Like they look. Yes, sir.
So if you feel like this, then they will start discussing these things.
Can it be an abdominal wall tumor?
No tumor.
No, sir. Generally, again, that expansion cuff and pulse is absent.
Why dermoid cyst? Because it is not even in the midline, right of midline, you said.
Yes, sir. So,
Lines of embryonic fusion, no? As per definition.
yes, sir. Yes, sir.
Then where is the line of embryonic fusion here?
Sorry, sir.
No issues. But no, remember, you say something, you have to justify how you reach that.
Yes, sir.
We should be able to give reason. Wow. Maybe you are thought of that. Why you are not questioning of writing, but you should be able to justify. What are the
Any hernias, you know, abdominal wall hernias?
any other hernias?
Yes, sir. Epigastric hernia, umbilical hernia, paraumbilical hernia, then lumbar hernia.
Any other?
Then, sir, Spigelian hernia.
Very good.
Then,
Where
there
is located in which part of abdomen?
Which part of that?
sir, it is located beneath the muscles of the abdomen in the Spigelian fossa. So, because of that, we can't always see it. But the patient comes with pain, and since the defect is kind of narrow, so chances of obstruction are also pretty high in those cases.
What is the exact site?
Is it below umbilicus or above umbilicus?
Sir, generally,
Is it below umbilicus or above umbilicus?
sir,
Spigelian. What is spigelian fascia? Spigelian line? Spigelian point?
yes, it's below umbilicus.
Samkit, you can help him. No problem. You can help Swarnava to give your right answer. Spigelian.
Because
It's below the umbilicus, where
below.
linea semilaris is joining lateral margin of the rectus. There, that is the point, phageal point. From there, phageal fascia reflects. So that point hernia occurs. It may go between the internal oblique and transverse muscle and so on. It may form an intraparietal hernia also. It often get like it may get strangulated also very easily, and may mimic abdominal lipoma because normally it is irreducible. So we will not be able to elicit proper impulse in such patients. So it may mimic abdominal wall swellings. Okay. So phygeal hernia you have to remember, especially if it is so in the lower below the umbilicus. Okay. You said some swelling below the umbilicus. It was not visible on inspection, only palpation. You also told spine syllable not very clearly felt, left side.
Yes, sir. That's paraumbilical.
Have you heard of a desmoid tumor?
Desmoid tumor, have you heard? What is desmoid tumor? Suppose this is not reducible, firm in consistency, you already told.
Yes,
Not
sir.
mobile, you told.
Yes, sir.
So we are telling this is, if it is so, it will be a desmoid tumor. What answer you have got? How will justify it is not desmoid tumor?
So desmoid to
Desmoid tumor.
expansile on curve, and it is non-cancer benign growth of the connective tissue. So we cannot differentiate from the. We can differentiate it from the hernia to the desmoid tumor by expansile curve.
Okay. How firm or hard it is.
Firm and hard, yes, sir.
There is no impulse on cuffing. Okay. Reducibility
Yes, sir.
will not be there. So it's common in females. That's why sir is asked. Desmoid tumor is common in females. Okay. That's why it is asked. Okay. So dermoid cyst writing is not better not write it, sir. Muthukumar, sir.
Yes, sir.
Better
That can be removed.
Better to remove, not write. Abdominal lipoma is okay, but here it is substantial impulse on coughing is there. But but even lower swelling, infraumbilical swelling also you said defect is there, reducibility is there. Okay, so that's why probably diagnosis will be only one. If at all abdominal lipoma may be accepted, not dermoid cyst. But when the discussion comes, no tumor, all other things, we should be able to give an answer. We should be able to think and say why it is not. So you should know the features, right? No, sir?
Yes, sir. Yes, sir.
So you should be able to give an answer why it is not. So you should have some backup knowledge about all these different conditions of the abdominal wall swellings. Abdominal wall swellings are not equal to hernia. Hernia is a part of it. So you should be able to give a differential diagnosis, and you should be able to tell why it is not. Understood, sir? No?
Yes, sir.
Okay.
What is special about epigastric hernia? You got two swellings. One is epigastric, other one is paraumbilical.
Yes, sir. Epigastric hernia, it is mostly because of decussation of the linea alba. It is more common in females, sir.
Yes.
And then in 20% of the cases, there are multiple defects instead of a single defect. So we call that a Swiss cheese appearance, which we see.
Special. Sir asked something special.
Specific.
So something special he has asked. Sir has asked.
You have written the first diagnosis ventral epigastric and then a paraumbilical. Both hernias are same, some difference is there.
Sir, initially it can also be sackless.
Which one?
Epigastric, sir.
That's all, simple, very good.
Sackless. Initially,
Only hernia without a sac is your
Sac.
epigastric.
Yes, sir. And then later it can develop a sac.
only epithelial fat will protrude out of the decussation.
That's all.
Yes, sir.
What is the difference between umbilical and paraumbilical hernia?
Sir, umbilical hernia, it is arising from the umbilicus, and paraumbilical is from adjacent to the umbilicus. Umbilical hernia, the paraumbilical hernia, since the defect size is smaller, there is more chances of strangulation than the umbilical hernia. And a lot of umbilical hernia we see in congenital anomalies also, where the during development the intestines and the abdominal contents, they come out, but they fail to go in. So in such cases, we wait for a few years. Because sometimes it naturally goes inside. Otherwise, yes, sir, surgically we manage.
Omontocele.
Yes, sir.
Omontocele. This is called.
Yes, sir.
What do you call? Omphalocele, sorry.
Omphalocele, yes, sir.
Omphalocele. That's why one of the reason I asked you, did you palpate the umbilicus for a cough impulse?
Yes, sir. Yes, sir.
I must keep the finger inside and just check. Suppose there is an impulse, means that umbilicus also there is a defect.
You have to put your finger while raising the head. You have to put your finger into the umbilicus and see whether there is a defect there or not.
Yes, sir.
It's important. what sir is informing you. Okay.
Yes.
So sir, we go to the next
Yes, sir.
slide, sir.
Yes, sir. Yes, sir.
Next slide, sir.
Keshav, anything to comment on the clinical Mathukumar, sir?
Nothing, sir.
Everything is covered. Yeah. Very well covered. Yes. Continue.
So, sir, all these investigations he has written, sir.
Yes, sir.
Comment
The
on-
blood investigations are routine, and for imaging we use USG or CT abdomen.
Suppose the patient is very thin, very thin built and emaciated. Any
Yes, sir.
investigation you want to do?
Sir, we can like suspect for carcinoma.
No, I'm not
So
talking
can
about
take
carcinoma.
sick.
Among this investigation, somebody is very skin and bones, very thin, emaciated. In that case,
anything else you want to do? Anything specific?
proteins, serum proteins.
Proteins, albumin.
Yes, sir. Albumin, serum
Serum
albumin.
protein. Somebody is means hypoalbuminized, muscle
Hypoalbumin can
is
be
there.
there.
They may develop hernia. Okay.
Why
Yes, sir.
CT you have written?
Yes, sir.
CT abdomen, why you have written?
Sir, like the epigastric hernia was small, so whether like in Richter's hernia or like any other underlying cause, like Spigelian hernia also, like which is
Your ultrasound will pick up that. First investigation, you written ultrasound, na?
yes, sir.
So you keep the probe and ask the patient to cough, that finishes. Why you want a CT?
When you will do the CT abdomen in hernia, ventral hernias?
Sir, any complications when we are suspecting like
Is
obstruction?
the indication?
And then, sir, sportsman hernia we do MRI or CT we go for.
No, CT volumetric in a large hernia. You have
Yes, sir.
what is domain? Abdominal wall domain law. You heard of that?
Yes, sir. Yes, sir. Abdominal wall domain is for loss of domain is there are two criteria, Sabaga's criteria index. So we calculate the volume of the hernia sac and divide it by either the total abdominal volume or by only the abdominal wall volume. And for like example in Sabaga's index, I think it's if it's more than 20%, then it is significant.
Oh.
So there is loss of domain, and we calculate it while doing CT. Yes, there's a formula. We check for anterior posterior diameter, then craniocordial diameter, and transverse diameter, and multiply by 0.52.
No, that's okay. But mainly to find out the whether there is loss of domain or not.
Oh yes, sir. The loss of domain or not. Yes, sir.
Because there is a loss of domain means what it means for you. If there is loss of domain.
Sir, we can't just put it back in because that can cause like increased pressure to the IVC and all. So those kind of complications might happen. We have to like increase
What it is called as? If there is
compartment syndrome.
Compartment.
Yes, sir. We can give carbon dioxide inflation for a few weeks. Then
okay,
after that,
don't worry about that. Don't worry about that. Why you have written gastroscopy?
sir, generally a lot of epigastric hernias are accompanied by peptic ulcers. So, so because of that, gastroscopy is indicated in epigastric hernias. Patient, if they are presenting with pain, will miss that if we do. We only cut.
Okay, we'll go to the next slide, sir.
Yes, sir. Yes, sir.
Yes, sir.
Next slide. Okay, treatment here as told ventral hernia mesh repair, underlay mesh placement, open.
What is this? What is this underlay?
Sir, depending on where we are placing the mesh, whether it's above the rectus muscle, between the
Why can't you do it on onlay mesh? Why you are putting underlay?
sir, this patient, this treatment was for this patient. This treatment was chosen, and so sir, that is why we highlighted that part. Sir.
No, yeah, which is usually we'll put underlay or onlay in ventral hernia, umbilical hernia or paraumbilical hernia or epigastric hernia. Which is better?
Sir, underlay only.
This is better, Samkit.
No, you open, identify the defect, reduce the contents, close the defect,
Yes, sir.
then keep the mesh on it. That is only practical now.
Just close the defect and come. Why you want to place the mesh?
Sir, because recurrence chance can occur if you're not placing mesh. So that gives an extra layer of protection.
What are the guidelines for the use of mesh?
Sir, we use, if we are doing intra-abdominal mesh, then we use PTFE material because
No.
that doesn't call bowel.
This is what I'm asking. I'm
Yes, sir.
asking what is the guideline to use mesh or no mesh?
What's the criteria to use mesh or no mesh? When we will not use mesh.
Sir, generally in congenital hernias, we don't use
No,
mesh.
talk about this case.
Don't talk about congenital hernia here.
This particular case, no?
You talk about your case.
Your case.
Why not?
Guideline.
Sir, in case of multiple defect is present, then we use mesh. Or if the defect is more than 2 centimeter, we use mesh.
And you will not use mesh if there is triangulation. Otherwise, you have to place mesh. Okay? If there is
Yes, sir.
triangulation or if there is even you operate, if there is because of the adhesion, if you open the bowel, perforate the bowel, injure the bowel, then may have a difficulty in placing a mesh. Because contaminated field mesh placement is difficult. It cannot be.
Yes, sir.
In those situations, you do a primary repair. Otherwise, anything more than 2 centimeter, currently set to that, you have to use the mesh. Okay, unless there is infection or strangulation. Okay.
What is the purpose of mesh?
Sir, to induce fibrosis.
Yes.
And gives the
Yes, sir, a mechanical barrier also.
barrier and withstand the pressure.
Yes, sir.
Okay. Right. So, anything to ask, sir, Muthukumar, sir?
This modified shoelace and all are not applicable for this case, no, sir.
Yes, sir. Yes, sir. This is not useful in this way.
You know about anything about modified shoelace technique? For a huge hernia, and it's too small. Your case is too small for all those things.
Yes, sir.
Primary closure and onlay mesh will be the correct answer for your level. They're doing
Yes, sir.
laparoscopy, you can talk about other things. Okay.
Yes, sir.
Modified shoelace, all those things are not useful in this patient. Okay. Like sir rightly told. What is relevant? Yes, underlay, mainly not onlay, never onlay. And IPOM, yes. Laparoscopy, if cost is okay. IPOM is okay. Okay. So, sir, anything to Keshav or sir, Muthukumar, sir, Manoharan, sir, anything to add on to this, because it is a common long case. Examination of standing is important. Cuff impulse, expansal cuff impulse is important. You said already rectal examination and perineal examination in females, at least they have to mention. Then head raising and defect to assess and whatever the precipitating factors to look for. That is also
Skin pinchability.
Skin pinchability, expansal impulse, defect to look for, and other precipitating factors, other systems. All those things are the important. Investigations, of course, ultrasound sufficient in small, otherwise CT volumetry in a large hernia, dynamic CT volumetry you have to do in a large hernias. Mesh placement is the standard treatment, mainly underlay, otherwise laparoscopic in ventral hernia. Ventral hernia, primary incisional hernia is after surgery. So, anything to comment, sir? Anything to comment their presentation and add on to this as far as UGC is concerned?
They have done a very, very, very excellent presentation, sir. For undergraduates, they have done very thoroughly end to end. So remember, the basic thing is you have to stick to the examination of a swelling part, like given in thus, thoroughly inspection and palpation, and always remember the sir also told abdominal examination means you must not confine only to that part. The rest of the abdomen also you have to say and about organomegaly, ascites, and any other things, and conclude with your lymph node means supraclavian.
Yes, sir.
Thank you, sir.
Muthukumar, sir, anything to comment, sir?
It's a good presentation, sir.
Sir.
Only thing is, you must be complete and See, you are mentioning uncomplicated, then you are mentioning complication. That type of repetition can be avoided.
Yes, sir. Yes,
Simple, complete diagnosis.
yes, sir. Yes, sir.
Simple, complete diagnosis is
Keshav,
Yes, sir. Thank you.
any comments or anything? Subhiksha, meantime, put my presentation. Do you have anything to comment? Yes, sir. Yes, sir. Subhiksha, put my presentation.
Thank you, sir.
Thank you. You presented well.
Thank you, sir.
Both of you did very well. Congrats
Thank
to
you, sir.
very bold and very neat, tidy presentation.
I'll just go through my
Thank you, sir.
just
Thank you,
brief.
sir.
Thank you.
Ventral hernia.
Congratulations. Did well.
Thank you.
Subhiksha, put my PPT. Subhiksha. Okay. Subhiksha, any problem with the PPT? When they start with just examination in history is very important in that for students and mainly impulse on coughing and head rising test. I'll just go through that. Next slide. Subhisha, next slide. Next, this is what previous laparotomy details, wound dissection, method of healing, straining, smoking, diabetes and metabolic disease, liver disease, renal disease. All those things are the causes for ventral hernia or incisional hernia or recurrent hernia, features of obstruction. All this history you have to ask in detail whenever in ventral hernia, incisional hernia, whatever the things. These are the important thing. History of when if there is a previous year laparotomy history. So detail wound dissection, method of healing, primary or secondary, other things you have to ask. Next slide. So examination, infection, palpation, percussion, and rectal and systemic examination I have put in briefly in a table. So standing position important, expansion impulse cuffing I have told, size, shape, extent, number. Number is important, cystis hernias. Scar description is important. Skin over the swelling, already sir has told that. Reducible tenderness, go back. Assessment of defect, again important. Percussion over the hernia in standing, that's important. You usually percuss in standing position. Presence of free fluid, which I have discussed. Measuring hernia in standing and during coughing. This is the applying EHS classification that is there in the book. There is for primary different, for incisional hernia different. The rectal examination is important. Other systems and loss of domain is the most taking important part in the managing the assessing the hernia and ventral hernia and managing the ventral hernia. So loss of domain meaning is the how much hernia is there, a content which is not getting reduced to the main abdominal cavity. That's called loss of domain. So that word you should know in any ventral or incisional hernia. So EHS classification is more important currently, is a standard actually. Next slide. So this slide, this table is very important. So this is the meaning single, multiple defect. So width is different. This is the how big it is hernia. In this patient, loss of domain is very important. So CT volumetry is very important in a patient like this. Next slide. So this is the EHS classification for primary abdominal hernia. I'm not going to detail it, but this is important for incisional hernia, usually kept as a long case in the exam. So these things midline M1, M2, M3, M4, M5, L1, L2, and 3, 4. So size width wise, less than 4 to 10, and more than 10. And newer width has come 5 to 10, 10 to 15, 15 to 20, more than 20, like that. Any additional modifications have come actually. This is the standard one. So this EHS classification has become standard for primary ventral hernia or incisional hernia. Ventral hernia as such is classified as primary and incisional. Next slide. So this is again diagrammatic view of how to assess this patient. What is the M1, 3 centimeter, M2, M3, above M4, M5, and laterally L1, L2. L1 is subcostal, L2 is flank, L3 is iliac, L4 is lumbar. So this is the sackless epigastric hernia typical look. This is the Swiss cheese pattern. See that it's very large ventral hernia. In such a patient, you have to think of abdominal tumor and other things. See that? This is what sir told. Other abdominal wall tumors or abdominal mass as such may mimic like this. So lying down, it may get reduced. So clinical examination is very important in such patient to say this is the ventral hernia. Next slide. So all these things are the different incisional hernias, ventral hernias, and measuring this one is important. This ascites causing the large umbilical hernia, very common. In ascites, portal hypertension patient, massive ascites causes umbilical hernia. Here you can see the epigastric hernia and umbilical hernia both. Again, incisional hernia here, again incisional hernia here, again ascites with the umbilical hernia here. So different types of hernias, ventral hernias you can see here. Next slide. So this is what he has already told. Tanaka index and Sabag index. This is the hernial sac volume. This is the abdominal cavity volume. So more precise is Sabag index, but difficult to calculate. Easier is Tanaka index. It's less precise than the Sabaka, but easier to calculate. If it is in the dimension more than 0.25, this is more than 20% wise, more than 20%. So loss of domain definition, and this one is important. These two index, maybe MCQ or whatever it is. So you should know what is the meaning of that. By which this diagram will be able to understand that. So this is the strangulated epigastric hernia. You can see that redness, skin involvement, features of strangulation you can make out. You can get strangulated ventral after long-standing time actually. So this is important currently. It's a newer thing, but definitely very useful and very important as such. So CT volumetry is way you will assess this one. So CT, that's how CT comes in the picture in a large ventral hernias. Next slide. So this is the radiologically how you measure the loss of domain. Already he has told actually dimensions, AP, transverse, craniocaudal, what is the meaning. So this is the diagram. Just want to show both hernial sac volume, abdominal compartment volume, and total peritoneal volume. So the three things you have to always know. So dimension is this factor is 0.52 in this. Common factor is 0.52. Next slide. So this is a CT, how to do CT scans, a large hernia like this, and assess the CT volumetry. Actual CT is important in such patient always. Next slide. So if it is loss of domain, then already we have discussed that pneumoperitoneum to create and botulinum toxin injection 1 month before surgery or 3 or 4 weeks before surgery, and other methods also. So you have to, otherwise they'll go for abdominal compartment syndrome, may not be able to. So different methods are there. So ventral hernia classification important. IPOM is intraperitoneal online mesh repair. That's a good standard. IPOM plus it, you have to close the defect as the standard currently. Next slide. Next slide. So component separation technique is becoming more and more popular, both either open or laparoscopic. In that posterior component separation is more precise than the anterior. So all surgeons should learn that. Now currently laparoscopically or endoscopically and robotic wise also they will do CST in a large hernia like whatever picture I have shown. So component separation technique is a short note for students. They should remember what is it. Becoming in a large hernia, it is very, very useful. So creation of pneumoperitoneum, already preoperative progressive pneumo, is a PPP. Word is preoperative progressive pneumoperitoneum. And with the injection of botulinum toxin, because it muscle get relaxed, so muscle distance adequately, so that capacity of the abdominal cavity will be increased over the period of month, so that you can push the content back into the abdominal cavity. So you have to reduce the domain, loss of domain. You have to correct the loss of domain, so that the subexact will correct the domain. Already different less than 2 centimeters, you can do a primary closure, which already Keshav has discussed. So other than that, everything is a mesh repair actually, usually underlay mesh repair. So component separation technique is important. You can read that, and how to correct the loss of domain. That's also very important. A large hernia. These are the two things you have to always remember. Next slide. So remember complications, we already were told pain, irreducibility, obstruction, strangulation. Complications, surgery also important. Infection, wound adhesions, recurrence, abdominal compartment syndrome is the most important. Bowel injury can occur because a lot of adhesions, when you dissect the separate the adhesions, it may injure the bowel, then it will become a problem. Sepsis can occur, may lose the patient and may not be able to push the mesh, and mesh may get extruded or infected. So the problem different from a large hernia, not a small or medium hernias. Large hernia, recurrent hernias, incisional hernias. It's a challenge actually to manage. Most of the surgeons like Keshav may not be, sir may be knowing, Keshav may be knowing, Muthukumar, all of us have faced these problems and managed such patients. So next slide. So this is how exactly we'll place the mesh, retrorectus plane or underlay mesh. This is the epigastric hernia with the margin here. So this will mark it out for either defect, will mark it out for open, or laparoscopy also will mark it out like this to place the mesh actually, IPOM mesh when you place. So this is a sac actually, how exactly it looks. So mesh is actually polypropylene mesh will place in the retrorectus plane or preperitoneal plane. Preperitoneal is thin, very difficult to get a plane in a large hernias. So we need to create a retrorectus plane. And if you want to be able to close the rectus, it's very important to have a dynamic stability of the abdominal wall. In such a situation, you have to add on to the component separation so that you can close the midline. So idea of component separation technique is to close the midline in a difficult case at large hernias. That is being achieved by component separation technique. Next slide. So this is IPOM, how exactly it looks like. You have to place is under the peritoneum. See the mesh here, tackers, absorber tackers are placed. So there is the mesh inside the peritoneal cavity. These are the tackers, how they look like for undergraduates. So 5 mm tackers, absorbable, you have to place. So I think all of us know that a simple thing, but UGs, it is how exactly it looks like. Next slide. So just to see, next slide. You can run the video in a differently. Here you can run, okay. Just 2 3 minutes video, how to examine. Always examine standing. See that, and measurement, all those M1, M2, M3, M4, L1, all those things, what type it is. So expansal impulse, see that, how to look for expansal impulse on cuffing, and head raising and checking the defect. See, that is defect will come more. So put the finger and check the defect. So measure the size. So defect is checked horizontally. See that, defect is checked horizontally, always. So we should know the examination. So mark it out, always mark the defect, then measure it, like whatever the EHS classification, M1, M2, M3, M4, the way it is. If it may be combination of that, maybe above the umbilicus, below the umbilicus, so it becomes M3, M4, and laterally how much it becomes L2, L3, like that. So this is a very large hernia. So it's a mild, moderate, severe, like that, large, very large hernia. So loss of domain may be there. So that also has to be assessed by CT volumetry actually. So this marking is important to have a EHS classification, M1, M2, M3, M4, like this. So mark it so that, see that marking, same M1, M2, different levels are marked here. Then we see which level it comes. So lateral also how much it comes. So lateral marking also has to be done to have a EHS classification properly and name it. So that now you know the marking here. So you can see that M2, M3, like that. So which level it is there. So find out. So that's how exactly you will assess do the EHS classification. So mainly standing examination. Standing is very, very important. Even in inguinal hernia, examination standing is very, very crucial. Remember, same holds good for spine examination, other things, systemic examination, of course. I'm just mentioning that. Bowel sounds, you already told. So respiratory system is very, very important because maybe the causative factor. And PR is rectal examination is also equally important in a hernia. Percussion, liver dullness, percussion over the, for free fluid. Already sir has told that free fluid you always you have to mention, because I said it's one of the component. Rectal examination is very, very important in any hernia for that matter. So marking and expansal impulse, that's how exactly it looks, expansal impulse. I said it's a momentarily increase in the size of the swelling during act of the staining or appearance of the swelling. So it is a portal hypertension patient with the ascites. The fluid is there. That is how exactly it looks umbilical hernia. So very typical in portal hypertension, the massive ascites. Very typical look how they present with. So there will be free fluid always. So 15 dullets you have to check in these patients. All of you know how to do percussion the same way. So scar is assessment of scar. See that scar, how it protrudes out while coughing. It's a secondary healing. This scar, probably emergency surgery was done. So that detail history also has to be taken. So what surgery, emergency, for what it is, there may be peritonitis. So this is with a very big hernia. So you look at that. So requires a lot proper assessment of this patient. So abdominal compartment is okay or not, abdominal cavity is okay or not. If it is so, you have to assess. So it's a small paraumbilical hernia. So defect. Sir has already told, always examine the umbilicus. Others will miss. Defect may be there in the umbilicus. See that bowel, you can see the bowel there. When it's thin, so thin in the skin is so thin, bowel, abdomen is very thin. It again hernia. You can see that paraumbilical hernia just below the umbilicus. So this next slide, this is how exactly next slide. So briefly how to examine ventral hernia video I have shown. So my 8th edition book has come. I thank sir has written the foreword. Manoharan sir, thank you very much sir for your kind good wordings in my foreword. And my website, I request everybody to subscribe and go through. It's free, and daily MCQs are there. Please go through that, try to answer. And a lot of videos are already around 420 lectures and videos are there. Examination, suturing, different examinations, different brief lectures are there. Students always go through that and learn. Lot of MCQ, already around 200, 300 MCQs are there. You can learn that. And my new edition with the additional supportive MCQ book also there. So it will be very useful. Other than my clinical book, it's very useful. It got video of examining the patient with the instruments and other things. Definitely, it will be useful. Of course, operative surgery mainly for postgraduate, a big book. I request again all students and viewers to subscribe my website to learn in day-to-day basis. I request Swarnava and Samkit to make everybody to subscribe my book, my website actually to learn.
Yes,
Again, thank you everybody. Thank you all viewers. Thank you,
Thank you.